Hello, everyone, and welcome to Ask Us Anything, where the ID co-founders and some teaching team members come on and help us answer all of your anatomy questions. This is episode 6, if you can believe it, 6 weeks of the pandemic. We have spent Sundays together doing these amazing calls, and we are having so much fun. It is not getting old, and more questions are coming in. I'm Dr. Kathy Dooley. I'm one of your ID co-founders, chiropractic rehab specialist and anatomy instructor. Super excited to be here with the other amazing co-founders. Dr. Folckomer.
Hi, everyone. I'm Dr. Anna Folckomer, one of your co-hosts and co-founders for Immaculate Dissection. Ask Us Anything. Super excited to be with you today.
And we cannot leave out the amazing Danny Quirk, co-founder.
Hey everybody, Danny here, artist for Immaculate Dissection. Happy to be on call and chat with everybody today.
And we all want to be hanging out wherever you are. The most gorgeous backdrop ever. It looks not real. It looks like one of those fake backdrops that people are using on Zoom calls. But really, really nice. We also have the incredible, incomparable Dr. Anna Folckomer, Dr. Monica Chadha, also amazing. Monica, can you tell us a little bit about yourself? Hold on a second. Might need your help, Anna. Can't unmute her.
Hi, everybody. I'm Dr. Monica Chadha from Toronto. I'm a chiropractor, and thanks so much for having me back again. I'm really excited to be here.
Wonderful. We're so glad to have you. And last but not least, Dr. Kris Kirby of Missouri. Anna, maybe you can help me unmute him. Mine's not working for some reason.
Got it.
Hey guys, Dr. Kris Kirby here, chiropractor in Southern Missouri, right now in Northern Arkansas. We're taking my daughter out camping for the weekend.
Awesome. I love camping. Very, very cool. Well, we'll call on you guys to also facilitate some learning and some knowledge. And for our attendees today, we would love for you guys to post any questions that you have. We have some questions from people who can't be here with us tonight, but we do want to be able to answer your questions too. So you can use the chat box below. It's under the very bottom. You'll see a button that says share screen in green. And to the left of that is going to be a chat box. So you click on that and post your question, and we'll do our best to get to it. So we have some really great questions this evening, and they're posted on our social media. And we just want to make sure that we get them answered for the people who couldn't join us live. And it did stimulate quite a bit of thought and some really cool things to discuss. One question was, why do the neck muscles like to switch on so much when doing abdominal exercises, like crunches and leg lifts? This amazing lady has been teaching Pilates for years and finds it to be an issue with clients and herself personally. Well, we cover this in our ID1 Core Concepts course, and then we hit it again in ID6 when we talk about movement subsystems and the intrinsic core stability system. So we have 2 major reasons why the neck muscles recruit, and Dr. Folckomer and I will cover a lot of them. Dr. Folckomer is going to cover the diaphragmatic part because she is the queen of all things diaphragm. She teaches the diaphragm section. I'll cover another part, and so if we're starting out at one major area, it would be the thoracolumbar fascia. And if you're not well versed on the thoracolumbar fascia yet, ID certainly encourages you to get that knowledge base down. This is an excerpt from the manual. You're seeing Danny Quirk's amazing artwork here. And this artwork is of the thoracolumbar fascia's 3 major layers. They each have 2 laminates. And so the fascia actually becomes an aponeurosis, a broad flat tendon, through which 6 muscles on each side attach. Those 6 muscles you can actually see in part here. Transversus abdominis and internal abdominal oblique attached to the more anterior parts. Multifidus we can't quite see here, but we see the erector spinae attaching to the middle layer. And then to the posterior layer, we have things like latissimus dorsi, which has been cut out here, and gluteus maximus, which has been cut away here. So 6 muscles each side. And through this thoracolumbar fascia, we can actually build gut pressure to protect the 2 most vulnerable intervertebral segments, L4, L5, and L5S1. And if you think about it, there are really no muscles on the front of you between L4, L5, L5S1 that can protect you from discogenic changes or any kind of changes away from your lordosis. Really, the only things you have are multifidus and lumbar erectors in this thoracolumbar fascia to protect you. So if these areas get tight little kinks in them, much like a kink of a slinky, and they can't dissipate force through their 6 muscles, then we actually have this posterior laminate, which Danny has drawn here, superficial or posterior to the erector spinae. This fascia comes up and connects up to neck musculature. You're seeing it over here connecting over to things like splenius capitis, things like levator scapula, trapezius, and scalenes. And they do this, and then if you are basically not able to build proper gut pressure, it tenses this fascia and you'll start to raise the shoulders and actually breathe, or you'll start to recruit things up at the neck for things down low. So when you're trying to maintain lordosis and trying to maintain gut pressure to protect your center of mass at L4, L5, L5S1, and you can't suddenly do it, you will recruit what's available to you. Another reason is that we have a cervical lordosis and a lumbar lordosis. So things that wire together kind of fire together, right? These are the curves that you earn. So when you start to first pick your head up, you're also starting to build your lumbar lordosis. So, you know, when you get in trouble and you can't quite get core stability during a supine drill, like a leg lift or a crunch, what you'll do is you'll start to recruit what's available to you. You might go into back hyperextension, hyperlordosis, and then you might start to recruit these muscles up top. So in ID, we teach people to not do that. We teach them to learn how to let the neck be neck muscles and to retrain the core to be core muscles. This is one of the 2 major anatomic reasons, and it's a concept called irradiation of tension, right? So if I can't get the tension here, I can irradiate it up and try to recruit something that's available. Dr. Folckomer is going to hit you with the diaphragm, and I'm going to pull up a picture for her, but she can get you started on the diaphragm, and I'll pin your video here.
Cool. All right. So this is kind of one of those things you can't unsee, right? Once you learn about it, once you know that this is a pattern that people experience, you just sort of start to see it everywhere. I know that, you know, and especially right now when a lot of people are taking classes online, you know, group fitness classes and things like that, I'm sure that somebody on this call is guilty of like looking at all the participants and their alignment and things like that. So the thing is that, you know, just like Kathy was saying, that you'll use whatever's available to you and you'll recruit whatever's available to you. The trick there is that when we talk about the diaphragm in ID1, this is the point at which we introduce the ID cues. Because in order to set yourself up for success, you have to have a nice, stable, neutral spine to build gut pressure on. And you also want to set yourself up for success so that the diaphragm can be the first thing to fire and then cue the rest of the abdominal muscles. And the diaphragm is interesting and unique in the sense that it is innervated by your cervical spine. And so when we're talking about the importance of neck positioning and how people will often sort of recruit their neck for, you know, just for the sheer fact that it's available to them. And, you know, it's that sort of that it's like that understudy that's ready to jump in and take over. Once you start to compromise the neck positioning, now you're compromising the diaphragm, because the diaphragm is going to be innervated by C3, C4, C5. And remember that as C3, C4, C5 keeps the diaphragm alive. And so if we start to lose that neck positioning, now we no longer have the diaphragm being that first muscle to fire as it's interdigitated with TVA to, you know, sort of, we were seeing this first domino to sort of fall, and it starts to perpetuate the cycle a little bit. Because now if you don't have those things available to use, then just like Kathy was saying, you're going to use what's available to you. And if we start to compromise our lordosis in the cervical spine, now we're compromising the lordosis of the lumbar spine. If we've got a diaphragmatic dysfunction, then it's very possible through a viscerosomatic reflex that people will start to hinge through their thoracic spine. And that's going to be also where abdominal muscles are innervated. So, this is a great picture. So you can see the phrenic nerve coming out of the 3rd, 4th, and 5th cervical vertebrae there, coming down and around that pericardium, and then sort of spreading out into the muscle fibers here of the diaphragm. And so if your neck goes, you can't use your diaphragm at its optimal capacity. And so that's why it's a perfect segue into the discussion of the ID cues, which we just really cannot, you know, mention too much, really. Like we say these over and over and over and over and over again. We have neck long and chin back so that you can keep those cervical foramen patent and open, so that we can fire through that phrenic nerve and have, you know, the best chance of being able to optimally move our diaphragm to then cue all of the remaining structures and not perpetuate this cycle, because your body's smart. It's going to get stuff done, and not you throw athleticism on top of that and you're going to do whatever you're going to do. So we want to set people up for success to move on a stable platform in a way that is safe for them.
Love it. Danny, would you want to add some more? You had a great video, Danny, kind of piggybacking on what Anna was saying about like neck position while you were working. And it's been a very popular video circulating on our social media about posturing and being able to breathe. You want to piggyback on that a little bit, and I'll make sure to share with them the video as well. Oh, hold on, Danny, sorry. How about now?
Okay, cool. I think there's a game of mute tag going on.
Sorry about that. I was trying to avoid that.
It's all good. It's all good. No worries. No, but it's true though. Like again, like you kind of get into positioning and posturing and whatnot, and it's really kind of cool how again, like diaphragm is going to cue a lot of these structures that have attachment to the thoracolumbar fascia. But if diaphragm is malaligned or not really firing properly, it's going to basically set all sorts of things off and whatnot, and then body's going to try to recruit, as you guys were saying, to just get the job done. So in terms of positioning and posturing kind of there though, like I had really just found that like when working in like a very hunched position, or like just not having proper load share or properly maintained spine in terms of movement, or I guess lack of movement for that matter, it was putting a lot of compromise on those structures, and like not being able to breathe properly, like through diaphragm, through whatever else, was doing a lot of that neck breathing, was doing a lot of like that chest breathing that was coming from structures being recruited to breathe because proper muscles for breathing just weren't cutting it. So again, body was just trying to get job done, do things as efficiently as possible, and coming into the day, it wasn't about it was about staying alive and whatnot. So it's definitely pretty cool how the again, like through networks like thoracolumbar fascia, where there's attachments to different types of muscles that have different functions in inhalation, from importance to working to getting job done, how they can all be kind of communicated through that same fiber and that same tissue.
If you guys have missed it, you guys got to go to our Instagram or our Facebook page and see Danny's super awesome video. I pulled up here for you and screen shared it. And Danny talks about everything that Ann and I were describing anatomically about neck position and chin position, chest wide, ribs down. Danny goes over the cues in the video and talks about how it not only resets his neck and posture, but it relieves a lot of tension on organs down low. So if you want good core stability, you've got to have a really good neck position, and you can't be using the neck for core stability control. So for the person who asked the question, which I think is a very fair and an honest one, I hope that this answers that for you, and we hope that you continue to discourage them from using their neck for core stability. It can be irradiated and recruit along with, but not in absentia of core recruitment. And if you're finding people that are using their neck for stuff, you need to get them to down-regulate it as much as you can. Monica, Chris, raise your hand if you want me to unmute you. I definitely can try. Did we cover it all? You guys good? Covered it all? Good. All right. Well, let me know if you, okay, great. So one of our other questions, which I thought is quite excellent, I just want to give it its good due notice here. A gentleman asked if we could assess and treat lowered limb tendinopathy, and for example, Achilles tendinopathy or patellar tendinopathy, especially in athletes. And so this is one of my passion projects. So I'm really glad that this person asked. In immaculate dissection, we assess lower extremity inability to load share. So we clear them for a core stability problem, and then we look to see if they have a unilateral limb problem, if a hip is a driver of dysfunction or a foot is the driver of dysfunction. So I want to pull up some research for you on tendinopathy and how most people are getting it wrong. They're focusing too much on the painful area. And so when you have like Achilles tendinopathy, what do? Get stronger calves. Okay. What if the calves are strong and overriding something to begin with, right? And then patellar tendinopathy, that's quadriceps dominance, right? Both Achilles tendinopathy and quadriceps tendinopathy tend to go with excessive forefoot weight bearing, like an athletic position, and not being able to engage the posterior chain, which is wired not to the forefoot, but to the hind foot. And we really try to make things as simple as possible for people in ID by holding these true rules of finding out if a foot is a driver or if a hip is a driver of the dysfunction of the lower limb. That's A, despite where they feel the pain. And then also appreciating the pain and seeing if it's functional painful tissue or dysfunctional painful tissue. Because a lot of times what we find is that the site of pain is not always the source of it, in the great words of Carol Levitt. So to show you what you should look for is with both Achilles tendinopathy and with patellar tendinopathy, since the gentleman gave that example, is something we do in ID6 called the deep longitudinal subsystem. And this art by Danny and the content by Dr. Folckomer and I is kind of expanding upon Dr. Andrew Valimin's movement subsystems. And one of his movement subsystems was the deep longitudinal subsystem. And the deep longitudinal subsystem is when people will use a structure like gastroc and soleus when something here in the green is not available. And these are things that control the pelvis. Your main goal as an upright person is to be able to control the pelvic movement because that is your center of mass, right? To protect the lumbar spine because it innervates everything, and also to create lumbopelvic and abdominal stability. So when one can't use the green structures, they tend to recruit things like this. You can see that these are in pink over here and that this is in yellow. A yellow structure for us at ID6 is called a secondary synergist. So synergistic dominance can happen. With Achilles tendinopathy, what we tend to find is that someone has synergistic dominance, they're missing hamstrings, and so they start to use their calf. That's almost everyone with Achilles tendinopathies. And then rectus femoris, muscles like this, are antagonists to this pathway. So they'll start to put more weight in the forefoot and now start to use antagonists, even just secondary antagonists like rec fem. Now here's the kicker that I think is so fascinating, is that the more painful that a tendon becomes, the more efficient your system gets at that pathology. And that's what the research supports. It'll blow your mind, because you would think that pain would be a discouragement, but it's not to an athlete, because it's their path of least resistance. It's what they know and what they've programmed. And so what they've seen is that in research, especially with the patellar tendon, that a person will be painful, but will out jump possibly someone that's not painful. So they get really, really good at their bad pattern. It's a concept called neurogenic inhibition. So tendons have a ton of mechanoreceptor type 3, much like ligaments do, right? They're very different than muscles in that regard. And they send this information up through the cerebellar system, to the proprioceptive system, and then up through the parietal lobe once they get past the thalamus. And when they get up there, the body will create what's called a neurogenic inhibition of tissue around it, which means it'll shut down your hamstrings. It'll shut them down because they're antagonists to the quads, the things that you're keying yourself to use, which puts enormous tension on the patellar tendon, and it just perpetuates the fact that they become very good at their bad pattern because they have no way out of it, because they have reciprocal inhibition happening and neurogenic inhibition happening. This is not my idea, by the way. This is a really nice peer-reviewed article, and so I'll screen share it so you guys can see it. And so the article, and I can put it underneath the Facebook post for the YouTube, and I'll put it in the YouTube if you want. It's this article in British Medical Journal, the sports medicine division, and it's on tendon neuroplastic training. And so we don't get to it in ID2 enough because we have so much to cover. It's a very dense course. We mention TNT, we talk about tendon neuroplastic training, and we do tell people when they're doing what we call pendulums to do them a little slower when they get to tendons. Slow, heavy, slow contractions are what tendons respond to. So if you're trying to heal this inflammatory reaction of Achilles tendon or the patellar tendon, let's say, you have to make sure you get to the site, but also the source of the issue. If it's a dysfunctional, painful Achilles, then or patellar tendon, then you can certainly get a lot of focus on giving them, calf or quad exercises. But if you find in your ID assessment that it's functional painful tissue, which it normally is, then you can't just involve the calf. So what I see a lot of people doing is they'll get assigned a lot of calf raises, right? And they'll do them like up and down, up and down, up and down, or they'll give calf stretches. And those can absolutely be part of a healthy, program for the Achilles. Or quad extensions for patellar tendinopathy. But if that's all you're doing and you find actually that it's functional painful tissue, and the problem, like dysfunctional non-painful tissue, could be up at the hip, right? Or even down closer into the foot. If you ignore those things, it perpetuates the bad habit and perpetuates the neurogenic inhibition, which is why some people will spend a year in Achilles rehab and still feel not so great afterwards. So a moral to the story, from my end at least, is this. If I have somebody with tendinopathy, I first find out what they're good at, and then also look at what they may be missing. And you have to encourage your athletes to say, okay, look, you may have been taught like an athletic position where it's all in your forefoot, but you have to learn how to get your rear foot involved in it to learn how to counter the activity. And that's something that happens to me a lot in my clinical practice, and that's ID principle, to make sure to assess the person and not the symptom, right? So this article will be included, and you can read about heavy, slow contractions. It's like, they go really deep into the article. It's one of the best articles I've ever read about tendinopathy. And they talk about using a metronome because you can't even trust your own count. The research is pretty strict about heavy, slow contractions for tendons. My husband's a grip athlete, and he designed the ID4 coursework. And he also talks about how tendon strength can be the strength of your athleticism. And if you rupture a tendon or severely inflame it, it can be an end of a career for some people. And you probably have seen that in your various sports. The person that comes to mind to me is Kobe Bryant. I remember watching that playoff game where he ruptured his Achilles, and it was very slow to come back, and he was never quite the same. And all I want to do was say, don't just focus on the Achilles. Make sure you focus on the entire kinetic chain like you saw in that deep longitudinal subsystem. So in ID, we focus on, of course, we would encourage people to study heavy, slow resistance, which for us is just a pendulum done slowly and heavier weighted. But the focusing not so much on the symptom. Don't just look at the Achilles. Don't just get shockwave on the Achilles. Don't just get, ice rubs on your patella. To do more, because that person, you can sedate those areas that are inflamed. And yes, you do cross friction, which will get some blood flow to the area. But if you only do that, you're not going to change their pattern, and the odds of them getting more patellar tendinitis down the road or Achilles tendinitis down the road exponentially increases. Okay, so Dr. Folckomer, you want to piggyback on that at all? I know that you probably have a lot to say about that.
Sure. Yeah, I mean, and it ties in nicely with the last topic or last question as well, in the sense that, look, people use what's available to them. And so following a pretty basic formula of what are they good at, what are they missing, how can we optimize in-range, functionality of all tissues involved, and sort of put everybody back in their place. I mean, these tendinopathies are things that we often see not in people who are just like sitting at home not doing much, right? These are top athletes that we see this stuff in. And I know I see a lot of dancers who have both of these issues, and it's always so interesting to me when you see somebody who's doing something absolutely amazing. They're doing amazing jumps, they're doing amazing footwork or something like that, but yet they'll rupture an Achilles just stepping off a curb, or a basketball player that just happens to pivot the wrong way or goes up for a layup just slightly the wrong way, and that tissue capacity, that threshold, is surpassed and breached. And so that's a long time coming, and I think that with the ID sort of formula that we use and that we approach everything from this place of like, wow, it's so interesting that your body is doing this and it's using these mechanisms. I want to understand why. I want to understand why you're using the things that you're using so that we can make you optimized. And, you're only taking something away from somebody if it's working too hard, and you're only doing it if you give them what they didn't necessarily have in the first place, which does add longevity to a career, and it does add overall safety. And I think that athletes, never mind even the neurology of the sort of cortical inhibition part, I think athletes are used to being uncomfortable sometimes. They sort of expect, like, well, I train hard, so I probably will feel it. And I don't know that that's necessarily correct. I think that we have, I think that if we throw too much of that at athletes, then we might overlook things that could, prevent them from having some sort of career-ending moment. So, you know, we're going to approach this just like we would. Nobody's going to get a pass. We're going to approach it just like we would any other thing. Is this dysfunction coming from the hip? Is it coming from the core? I mean, you love it when people have bilateral tendinopathies, right? And then I know that as an acupuncturist, I was shown, I don't even know how many protocols of like just tons of needles around both knees. It never quite sat right with me, because it was just like, well, why am I just bringing more proprioception to their knees with these? I mean, at the very least, we can talk about, you know, on another day how acupuncture works, but at the very least, it's proprioceptive. Why am I going to bring more attention to an area that's already screaming at them? You know, I think that that's where an assessment really, really comes in handy. And so, you know, we are going to assess them just like we would anything else. And then because there is tendinous involvement with this stuff, and it does tend to rehab and respond to slightly different movement, we add that extra component in there with the metronomes, and we give them, you know, really honest feedback about like, hey, tendons take a little while, but that's okay. You know, we're going to calm down the noise and sort of give you what you didn't have in the first place that helped create this, and, you know, help you find your foot placement if you tend to be forefoot dominant, and, you know, and then it actually just, it works out really, really nicely if you just approach it from this place of problem solving that ID really sort of stays tried and true to. So
I love the fact that you said be honest about how long it takes. When it comes to tendinopathies, because it's tendon and it's highly avascular, it takes time and due diligence, and you got to give them 6 months. You got to tell them honestly, look, I don't like to have to tell you this, but I have to be honest. If you have a tendinopathy, and it's especially a weight-bearing one, like not so much like the elbows and shoulders, but if it's on the lower limb, you got to give yourself a 6-month period, not only to revascularize the tissue, re-educate the tissue, but for a new collagen matrix to lay down. And typically, especially with Achilles, it'll come back thicker, which may not be fun for the patient, but it's actually not painful for it to be thicker, but it does come back a little stiff. So you have to tell them, like, look, there may be a little bit of reduced range after you do a partial rupture, like a grade 2 of this guy, or if it's tendinitis that's just progressed into an inflammatory cascade, it may thicken the tissue a little bit. And so you might tell them they may be doing a long haul type of strategy, and they have to change the way that they did things before, because the problem that got them into this, you can't keep doing the same thing and expect a different result. So tell them that, they need to do some TNT, tendon neuroplastic training. They need to find out where the dysfunction is mostly located, and they're going to have an assignment for a while. One of my patients with Achilles tendinopathy, I told her 6 months minimum. Doesn't mean you have to see me for 6 months, but you have to do these things I assigned for you 6 months minimum. Even when the pain is dissipating, that's when you're the most vulnerable. You gotta keep going. And she emailed me at the exact 6-month mark and said, it's gone. I cannot believe it. And I was like, you can, it's science, just all you got to do is not a fun, maybe 6 months that you have to do this TNT training, and you have to do these hip centration drills, and you have to change your gait, and you have to, do all these things that I suggest. But if you do it, you reorganize the anatomy, and the anatomy pays you back with coming back a little bit better than it was before. You may, if there's a little bit of rigidity in the tissue because of tendinosis, if you will, then you can work on that with time. You can work on that with time by coordinating all the tissues to work better as a unit. Danny, do you want to piggyback on anything we said here?
Yeah. Hey. So I did think that it was really interesting as to how, just again, kind of on the topic of just improper biomechanics leading to compensation methods and compensation patterns, kind of shows up in other areas all throughout the body. And again, like that really just kind of drives home and reiterates the importance of, what kind of would come from, properly loaded spine, properly loaded whatever else, so you can really get this proper biomechanics going in the first place. And what was kind of coming to mind initially when Kathy and Anna were talking was, it was just making me think of like, you don't have a screwdriver, so you use a butter knife to, change your screw. And after a while, that screw, the thread gets pretty worn down and doesn't really quite work optimally at that point in time. And again, just like, it gets the job done, it does what it's supposed to, but it's damaging and hurting things kind of in the process. So starting off, going back into mindsets where, working things from a proper platform and a proper setup right off the bat is definitely going to help a lot.
God, that's such a good analogy. Awesome. I'd love to go to one of the doctors on panel too, Dr. Kirby or Dr. Chadha, if you've had some experience. I know that Monica might be. So, there we go. Monica, let me.
All right.
You want to talk about some of your clinical cases?
Yeah, actually, not too long ago, I had a patient who had an Achilles tendinopathy, and it was pretty bad, very painful, and found out it was lumbopelvic functional instability. So it was, there's stuff going on bilaterally, and either I didn't do a good enough job explaining it, or it just wasn't fun to do, breathing and rehab. And so they left, went somewhere else, and then, a couple months down the road, injured the other side. So it was, sad, but also person was like, all right, I guess there's something going on both sides. Like, what am I doing? What do I do now? So it was just kind of eye opener for me, because it was nice, not nice for them, not nice for me, but nice in the fact that, to know that you can trace things back to something central and something away from the site of pain. I don't think it's important to constantly drive that pain. So, to piggyback off of what Anna was saying is, finding exactly where it's coming from so that you can take care of it more approprially.
I'm going to show what you were talking about, Dr. Chadha, with the posterior oblique subsystem. So Monica was talking about like a lumbopelvic strategy, which is deep longitudinal subsystem also, but it's also this posterior oblique subsystem, which we use in terminal stance, a push off, like on the back foot, which is where Achilles people really get into trouble. And so Dr. Monica was saying, like, these guys are shut down, right? Hamstrings are S1 mostly, right? And S1 on the bun, right? Gluteus maximus here, and how it connects to thoracolumbar aponeurosis to help with that smart spring we talked about earlier with the core. So if these guys are shut down by lumbopelvic stability, maybe like something stepping on their hose, going, they can't get their innervation, you'll use something down low that's S2 mediated. So the gastrocs are not dependent upon, this upper, sacral and lower lumbar. It's a little bit lower. And so they're getting a little bit spared, right? This is, hamstrings are, of course, part of the sciatic division, but they're receiving a little bit, of the higher motor units, where everything as you go lower gets a little bit lower. And so your body does that as a preservation tactic, to where if you get lumbosacral instability, like Dr. Monica is saying, you'll still have something to hold you up, like soleus and gastroc. The problem is that those guys are holding you up, and these big old structures, like Dr. Monica was saying, are knocked out. You will end up with another problem soon. And for her patient, it was just moving everything to the other side and compensating that way. And I don't know, when the student's ready, the teacher appears, and Monica, evidently they were really ready after having the secondary issue. So hopefully they resolved that. Did you have a good resolution after you started to work on the lumbopelvic stability issue?
Yeah, and it did take quite a long time. And I was very honest with them. It's not going to be fast, and it's not going to be fun, but slow and steady, and let's get there.
Right on. Awesome. I'm going to pin Dr. Kirby. Dr. Kirby, I know you've had some pretty good experience with ID and the use of tendinopathies. You want to share some of your insights?
Sure. I had a patient come in about in January, a collegiate basketball player that had been dealing with patellar tendinitis since high school. Just treated the knee. He had looking at our ID2 material and what we teach, put him through some very simple tests. Found out it was in the sagittal plane in the lumbopelvic area. We started giving him some slow pendulums, just like you said, for he couldn't access his posterior chain, and in his athletic stance about being able to push through the heel for S1. And we added some weight to it, and I just got a message, I think 2 weeks ago, and he's a 6'5" collegiate basketball player, and he's able to use his left foot. Now he's actually jumping off his left foot, and he just jumped over, he said, like his brother who's 6'7". So I think it's turning out well.
Oh my gosh. It's so amazing to hear these stories of athletes, how they can actually really excel with a parking brake on. I mean, a good example of that's Usain Bolt. The guy's always injured. The guy was always having like quad strains, and he's the fastest man on the planet, I think, still. And so it's like Anna said, you don't have to be in pain to be an athlete. In fact, you can argue that if we get to people early enough and we can really start to harmonize some stuff, maybe not make everything perfect, but having a general amount of symmetry for recruitment, that you can unlock more power and then train that unlocked period rather than training a dysfunctional pattern until it breaks down. Really, really awesome insights. Love that. The last question that we received was also a really good one. It was about the get up. So if you're not versed on the get up, we at Immaculate Dissection do this neurodevelopmental programming in ID2 coursework and ID6 coursework. We even sneak a little bit of it into 1 and 3. It's hard not to talk about neural development and how we get off the ground and how we move through space and how it was basically a DNA program, and our parents didn't teach us how to do it. So the person was asking, when the person's doing the sweep phase, this is when you go from basically going from a seated position in a palm prop to a tripod position. So you're basically moving from 7 to 9 to 10 month period of ambulation and fixing that. The person was asking what to do with that. So I have a video of, actually, I don't know if this person knows this, but I actually have a video on fixing the sweep. So we did it before ID was a thing, but I think it will help you to kind of see what she's asking. So let me just go to that video here. And again, I'll include these videos. This is me on the back of my parents' house. There's the pump handle moving to the ribs we were talking about the other day in ID Collaborative. But you can see me kind of going through the motions here. And let me just fast forward to where I'm going from the palm prop here. And I'm describing, sending the leg kind of underneath you and equally load sharing between the hand and foot, and then coming underneath the body. And so if the person's having a hard time sweeping the leg underneath, we can fix that by bringing you down to the elbow. And I'll do a search for that as I'm talking right now, but I know that we have an ID Get Up video that I'll share with you guys. And the ID Get Up freezes the person at the elbow phase of the prop. And I really like this Get Up even better than any Get Up I've seen, not just because I'm ID, but mostly because I think it really works for fixing problems. Most of the time, the problem in the sweep is the oblique that's facing down. So when the oblique is facing down, if that person has a trouble with force transfer, a trouble with being able to stabilize, you might find a problem here. This is the ID Get Up. And you'll see me here going from like a supine 90-90 position. Here we go. And then, that's right here. Sorry, guys. So you'll see me anchoring here, and then I'm going to pop up to the elbow like a Turkish Get Up, and then right here you'll see me sweep through. There's the sweep. Now a lot of people have a significant trouble with that phase, so what we do is we try to pull them down to where they have to hang out right here. Right there. So we have them stay on their elbow and practice lifting the hip up and tucking it underneath them. This will very quickly fix a sweep that is dysfunctional. And so if I fast forward a little bit, you'll see me kind of doing that a little slower here. And you can do it on the elbow prop phase and on the palm prop phase. And what it does is it wakes up the oblique that's facing down. And then you can help with force transfer to lift the pelvis off the ground with the oblique. The obliques often don't get regarded as being really important muscles in pulling the pelvis up. People give all the credit to QL. Well, I call the bluff, and ID does too. There's a girl in the club. So basically trying to avoid, there we go again with kicking in the face. So these are all the bad things that you could do in the Get Up. So as you watch this video, you'll see me fix a lot of this right here by keeping the pinkies pressed against the knees, and that activates the oblique because you're connecting the upper body to the lower body. And then as you see me prop up, just kind of hanging out at a lower place. And Dooley, where are you doing it? Right here. Okay. And right there. And see how on my elbow, lifting the hip up. Who's doing that? It's not QL. I mean, QL might be playing a small minor role in that. It is this. QL does not have attachments to your ribs that force transfer into the scapulothoracic joint. So if I'm going to put my weight on my elbow and my opposite foot, where way more weight is on this, facing down, right? I have to lift my pelvis up. It's not going to come from this foot over here. It's going to come from this oblique right here. Because now I'm connecting this limb's lift with this limb that's supporting it. So you can fix that by just having them go underneath themselves over and over like that. And then you do the same thing when they get to the hand. You lift and you tuck. If you don't feel your obliques after that, whoo, come and find us and we'll help you feel them. Because it is a crucial piece to be able to understand that the sweep, that tucking yourself underneath, is coming from the oblique that's facing down. And so a lot of people have trouble with this. So to fix it, we tell people to stay on their elbow for a while and lift the hip up and try to tuck it under and make sure you feel your oblique, because that's what's going to be pulling your pelvis underneath you. Dr. Folckomer, you want to piggyback on that?
Sure. Yeah, it's always really fun to see just filming this with your patients, or, you know, during quarantine land, having them just send you a video. But it's always really fun to see where a person gets stuck in the get up and what they were doing leading up to that point. Because it's very possible, like if this person didn't have oblique connectivity, they may not have had it up to that point either. And this was the part that actually caught them. And it's always so interesting to watch the micro adjustments that, you know, you can't appreciate until you like slow it down and watch it and make it painfully slow. And let me tell you, that elbow prop and hanging out there and then going to the sweep from there, like Jane Fonda's got nothing on that, you know, like this is, this is a whole new thing. So, but even whether you're doing a Turkish get up or a Czech get up and you're going just from those first few phases, I mean, like Kathy said, this is a neurodevelopmental progression. And so if you passed go before you necessarily had permission to, it might show up as a problem in a certain phase where, you know, it may mean that you didn't quite have what it took to get to that phase, and that regressing them and just, you know, helping them to find that place, because it's probably those teeny tiny little micro adjustments that people make where, you know, they go to activate their oblique, but in doing so, maybe they just lift a rib up slightly, or they go into just a little bit of a you know, thoracic extension moment or something, and just enough to knock out that oblique to continue to progress them forward into the rest of the phases of the get up. And it's those little micro adjustments that add up and then ultimately yield a phase that is just like, I don't know why I can't seem to get this. I don't know why I'm getting stuck here. Well, make sure that you pass all of the other checkpoints first before you start to question that. And you know, the oblique dysfunction absolutely shows up kind of along the way. It just may not have been enough to stick them at that point. But you know, hanging out there on your elbow and really finding that oblique position, your body won't forget it if you hang out there long enough. So it's really, really great. And I love the way that, you know, ID takes us through this and helps us really key into those tiny little adjustments and those tiny little things that people do to strategize their way through the get up. And, you know, we teach people how to do this from a really, really authentic place. And, you know, there is no passing go if you don't have permission to, even if it means you don't get all the way up to standing, maybe you just stay at the first or second, you know, phase of it. That's okay, because ultimately it's going to yield a better get up.
Yeah. If it starts to look ugly, why move forward? It's not some gift for my patient to do like a 24 kilo that looks like garbage and then a 12 kilo that is excellent. Why not just stay a little bit lower? If you have to cut the get up in half and you keep it, I've kept patients at the elbow prop phase for like 2 visits. I'm like, no, why would you move forward on that? If it doesn't look good now, it's not going to get better as it gets more complicated. So it's okay to not pass someone to the next phase. It may actually prevent them from having an injury and blaming the get up. So if you want to learn the ID get up, what we'll do is we'll send you a link to this also, and you can practice on your own. And certainly our ID courses will cover a lot of the biomechanics of what's actually happening in the get up. Just to quicken us up a little bit, we have a couple of questions from the gallery. I wanted to make sure we got those 3 questions out. I promise, guys, if you have more to say, just let me know. We just had some really good questions from the live participants. I want to make sure we get to them. One person asked, when a client has had gallbladder scope incision below the xiphoid, how does this impact the ability to have proper diaphragm and gut pressure? I'm going to give you an annoying answer. It depends. So I'm assuming the person has not had linea alba surgery and has had a 9th costal cartilage, kind of cut. I would say that if you're taking that cut and you're bypassing the diaphragm and coming around it, you could have a certain level of dysfunction created by scarring from the scopes. I think you can get, if the person is having a cholecystectomy, which it sounds like, and it was emergency and not laparoscopic, because they don't usually do that incision anymore. They'll do laparoscopic for that, and they'll go through the umbilicus and through 2 points in the abdomen. It depends. You have to assess it. You can't just assume the person's going to be dysfunctional. I mean, it could have been that the person had a lot of tightness before because of viscerosomatic refluxing from the gallbladder, a lot of discomfort and tightening of the tissue, and that the surgeon goes in and the tissue's already tight and the tissue tightens around it. And then you have a potential scarring also around that area and fibroblastic infiltrate. One of my colleagues calls it exogenous fibrogenic exudate, which is a fancy name for scar. So it just depends. I would say assess and don't guess. We have some pretty cool videos on our YouTube with Supine 9090, and we cover, how to really get good at coaching that area through our ID1 core concepts course. And pendulums, our movements through the ribs are really important because if the person got stiffness from the incision site. I've found also that people have surgeries and it doesn't affect me at all. Like people with appendectomy, and it doesn't affect their core stability at all, or they've had it worked on before. So I wouldn't say automatically assume that they would be dysfunctional. I would say the exact same thing that Dr. Folckomer, that Danny would say, that Dr. Kirby would say, and Dr. Chadha would say. No one gets a pass. Assess, assess, assess. And that's our ID mentality is, don't let yourself get too bogged down by the idea that they had a cholecystectomy, they had an incision below the xiphoid. To me, it means nothing unless I've done an assessment. That incision site is in something we call zone 1. And let me just pull up the picture so you can see again where the person's describing the cut. So xiphoid area is going to be located around here, right? But anteriorly, Danny has it actually ghosted here, right? And when they do the incision, if they're doing what I think the incision is, they're doing below xiphoid a little bit over towards the right. I don't love this incision. If I had a choice, it must be an emergency one because typically they won't do that. They'll do a linea alba cut or they'll do laparoscopic. But if they do the cut here or they do the cut from the side here, which they sometimes do, these cuts can cause a little bit more core stability problems than a linea alba cut. I would say sign me up for the linea alba cut. You're going to have the least amount of dysfunction potential through a bloodless plane of a tendon that was open to you during your embryonic development, but the surgeons don't agree with me because they always think about, how can I make a smaller, cleaner cut? And they don't care about the rehab that we do after. And they're not bad people. They just don't have to deal with the aftermath that we do after an incision. And so this area through here, through the costal margin, and this is actually a better picture over here, sorry. Right here, as I'm assuming where the incision was, absolutely can affect the diaphragm. Not just the diaphragm, it can affect transverse abdominis, internal abdominal oblique, rectus abdominis, the rectus sheaths. And so this area for us is called zone 1. And so they did an incision in the most important area. That's why we call it 1. It's the number 1 thing that we look for in all core assessment. And I would say assess and don't guess. I have no idea if it caused them diaphragm dysfunction, but it is worthy of your attention if it's on their history. And I mean, we're going to tell you in ID1 anyway to assess supine breathing in zone 1 anyway. On everyone, all the time. Dr. Folckomer, would you like to piggyback on that?
I have really nothing but the exact same things to say. I would approach this person just like I would any other person, and I'd take a mental note of their scar. you know, depending on, it's sometimes even with the incisions, it's not necessarily incision so much as it is the pathway that it took to get from the incision to the infected site. And that's particularly true for laparoscopic and things like that, where there's like multiple incisions and multiple tools, and they're doing like a lights, camera, action thing and kind of like burrowing through the abdomen. So, but again, like, you know, you can also have that person and they're totally fine. I love going, that's a scar. Let me check it. Wow, that scar is actually totally fine. You know, it's so, I don't want to superimpose with a confirmation bias that just because there's a scar or incision present that it's like thrown off their system. Of course, it's important to include it as a differential, but I can't be married to my differential diagnosis. And ultimately, I'm going to assess their abdomen just like I would anybody else's.
Awesome. Danny, Kris, Monica, if you have anything to add, just raise your hand and I'll pin your video. If not, just give me a thumbs up and I'll go to the next question. Okay, it looks like everybody's good. Awesome. So the next question is always a question we get asked at ID, especially ID2. What do you think about controlled articular rotations, which are often called CARs, as a preventative treatment for distal limb subtle aches and pains where one isn't immediately able to assess what's further up the chain? No. No one gets a pass on assessment. No. I'll tell you that, you know, me like moving my legs because they were tight actually afforded me quite an injurious state. Dr. Folckomer would tell you the same thing about herself. We both have had hamstring injuries that were pretty intense. And by moving it more, it became more dysfunctional. So controlled articulations, you know, made popular by a couple of different groups. We do understand why they're given. I do see them done in my own gym, and I don't have a huge problem with them for the most part. If you're trying to control the tension on something that's tight, you have to understand that it could be tight for a very good reason. And so tightness to us in ID, it means assessment is needed. So just doing controlled articulations for the sake of doing controlled articulations, I mean, other than increasing the, you know, the circulation to a joint, I get that. I think you got to be really careful. I mean, I've seen people do like 45 minutes worth of CARs before they even do like their workout. So just make sure they do CARs on every single joint and then hope for the best. And so I don't know, like we teach our clients how to assess themselves, you know, through, I mean, it takes 30 seconds to assess yourself. Why would you not have time? If you have 45 minutes for CARs, you have 30 seconds for an assessment. And so our assessments are very quick. I mean, you know, especially for the lower extremity, we do, you know, a single leg stance, half kneeling stance, a hip transitions. Our assessments are very fast. And so as we teach the client how to do it and be aware of their tightness, I don't think being on all fours and whipping your leg around in a controlled fashion necessarily gets it done either. And so to me, controlled articulations are very similar to throwing at a dartboard blindfolded, rather than opening your eyes, looking at the problem and throwing towards the bullseye. I mean, Anna, I remember us, I think at the same time being in the gym, and I remember you being assigned a controlled articulation, and nothing against them, but you know, you already have a lot of mobility. What do you think about as far as like why ID doesn't really focus too much on controlled articulation and gets more towards pendulum and balancing assessments?
Well, I think it's an opportunity to give somebody what they didn't have in the first place. And, you know, the thing that jumps out to me the most about this question is that if there isn't time for an assessment, there isn't time for a diagnosis. I mean, you just can't give an answer to a problem if you don't know what the problem is. You know, maybe some mobility drills are the right answer. I mean, we have versions of mobility drills in the form of pendulums, but they are within a certain controlled range that the person, you know, is allowed to move in and out of with these sort of cues in mind. And unfortunately, sometimes with the CARs, I see people sort of sacrificing one region of the body to kind of overly mobilize another part. And I also think that, you know, certainly within the dance community and within, you know, yoga communities and things like that, people are also just attracted to things that they're good at. I mean, I think that, you know, for people who like to approach things from a problem-solving strategy of mobilizing an area might be attracted to other techniques that continue to mobilize. And the problem is, well, what if it's not a mobility problem? And now we're bringing, you know, we're just sort of furthering that. It's not something that I necessarily want to, I like to move a lot, but I know that that is not what I need necessarily, because it's gotten me in a lot of trouble. And you know, as much as I don't necessarily want that to be true, because I like to kick and I like to do fun stuff, you can't lie with the assessment and the strategies that ultimately work and what doesn't. And I don't know, it's a really interesting question. It's a really fun place, and it's certainly nothing against cars. I just think it boils down to, like, I can't make a prescription for something that I'm not aware of the problem, just because it might be, it might also be stability. So I don't know.
I think it's really interesting that people are assigned them without an assessment process, and then they're doing them, and how do they know they're even doing them correctly? And if to me, it's like, if you have to assess the cars, why can't you just assess the movement anyway? And what I love about ID assessment, and I think that, you know, I've done cars, you know, way in my past. I mean, I think the best car on the planet is the Get Up.
Mm-hmm.
It has the most carryover into life. But I think if you're going to spend 40, you know, what was this, 5 minutes? 5 minutes on hip cars. Why don't you spend 5 minutes on the Get Up? And the Get Up does involve all controlled articulations and a self-assessment. And I mean, I guess you know, since I'm, you know, due to do 145 something Get Ups today, I would do 145 controlled articulations. But to me, like, when I was assigned them, I didn't see any benefit from them. I didn't really get anything out of it, but I would see these amazing videos on them, like, oh, this person after, you know, 10 minutes of cars was able to get this much range. And I'm like, well, what if they put a parking brake on themselves because they had to? Like, to me, it's just, you know, what I was able to do with a pendulum, an ID pendulum, in, you know, 2 minutes, along with, you know, like half kneeling balancing or whatever lunge Get Up I assigned, I was able to, you know, take care of the problem in a third of the time with quality assessment, and give, you know, somebody something that they needed. So I don't think that people should get a pass on assessment. I don't, you know, I think that you should, I think we all the ID teams probably going to agree on this, that, you know, once you learn the anatomy pretty well, and you figure out which is the tightest structure and the most dysfunctional structure, you can teach that to your client, and then they have a really empowered tool that's not just, hey, let's move through space and let's hope for the best. You know, I think that we can be better than that, to be honest. Nothing against them, like Anna said. It's just, you know, I think that ID takes it up a notch and gets a little bit more quality control in that. Awesome. Monica, Kirby, Danny, anything else to say? Just raise your hand if you have something to say about the concept of cars. Let me pin your video, Monica. And I can't unmute her. There we go.
Just a quick note to piggyback off of what you said, just how ID's pendulums with, you know, just today in study group for Toronto, we were looking at shoulder, we were looking at hip, and it took like 3 or 4 repetitions of a pendulum to get the same result, probably, or better result probably, on a stable platform that you could have gotten from cars. I think it's just efficiency. So there's that plays a huge role, and it's very specific to the person, exactly what they need, assessing the tight structure. So I don't know, for me, if I have 45 minutes with a patient, I can do 3 reps and I can then spend time educating them. That's huge.
I could not agree with you more. I think that in their own ways, pendulums are cars. You know, I think they're just, you know, really related to that person on the plane in which they're the most dysfunctional. It's kind of like Kirby was talking about with his tendinopathy patient. He found that the problem with I think it was patellar tendinopathy, Kirby, was a sagittal plane problem. And so he really focused on the sagittal plane rather than controlling their movement through all 3 axes. And so he was like, let me troubleshoot right to the problem. And then maybe that'll open up the other axes, and maybe it'll take a third of the time and be more efficient. It's hard enough to get my clients sometimes to do their homework. I mean, if I can increase the efficiency and get results faster, results are very, I don't know, motivating. And patients are results oriented, just like you. So anything else you guys want to add? That was awesome, Dr. Monica. Yeah, Kirby, let me just pin your video. Yep, you're live.
Yeah, I've really enjoyed, like we talked before, about how educating the patient actually empowers them. And I think they can take really a lot away from that visit to understand that we're getting to the root cause and the source of this thing, and not just giving them some, you know, some car stuff or different things that they just seem to really, the more you educate them on it, the more they understand, and it really empowers them to be able to monitor themselves. and to see that if you can correct this, what can happen.
I love it. I think that's awesome statement. Very, very good. Well, those are the questions that we have for this evening. We wanted to tell you, in case you're not, sure about ID, you want to read more about it, we have our website, www.IMMACULATEDissection.com, where we have 6 online courses, and we have 2 anatomy intro courses as well, one on meditation, one on pelvic floor. We also have this cool thing that we started last week that we are way too excited about. We just love it. It's called the ID Collaborative. The ID Collaborative is a series of talks that the ID teaching team gives on basic topics, and we have a minimum 1 per week for a year, and we actually already have 3 for the month of May, and it's not even over yet. So we're on a track to build you quite the library, and the talks are like, the membership is $200 plus a $9 PayPal fee per year, and you get at minimum 52 talks, which makes them less than $4 per talk. And then also you can buy them a la carte. So if you just like one topic, you can just buy like one of them. And we talk about like this, but we talk about one specific topic, and we pull up research articles, helpful links, and it's getting a lot of great feedback. We already have almost 70 members, so in our first week. So I think if you like this type of talk that we're having, we have it just in a little bit more of a structured format where we handle one topic. And you can read about all those topics on the Immaculate Dissection website. Just click on the very top, click on the ID Collaborative link, and you can look at all the cool things that we have coming up. On Tuesday, we're talking about Bell's palsy, right? Pretty cool topic. And I believe Friday is gait, if I have that right, Anna. I think so. And so you get to hear Dr. Folckomer and Danny and I talk some cool stuff about Bell's palsy and gait. Not anything to do with each other really, but they're topics I think that you guys will really enjoy. And I think we should give away a coupon. What do you think, Dr. Folckomer? Should we get these guys excited? Yeah? Danny, what do you think? Yeah? Yes. Kirby, Monica. Everybody, I got thumbs up for everybody. Give them $50. Okay. So we have a $50 USD coupon for the first person who answers in the chat box. Now, you may want to practice using your chat box right now. It's up to the left of the share screen. If you posed a question tonight, that's the same chat box that you use. And Dr. Folckomer and I are going to be watching it like a hawk right now. I'm looking right at it. And I need the first person to answer this question correctly, okay, for $50 off of one of our online courses. It doesn't work for the ID Collaborative, but it works for our ID 1, 2, 3, 4, 5, and 6 online courses, okay? So are you ready? Okay. Name 3 muscles that the person can recruit in their neck instead of using their thoracolumbar fascia. 3 muscles. Are you guys excited? I'm excited. What do people use when they can't use their thoracolumbar fascia? We covered several. We talked about the connection going up, the erector spinae, and connecting to some stuff. Don't be shy. We know there are a lot of you guys on this call. Oh, here we go. Excellent. So we have the first correct answer is Christine. Christine, she says scalene levator scapula and splenius. Wow, nicely done. It just so happens that those 3 structures can absolutely over-recruit when the thoracolumbar fascia gets down-regulated due to their connection to the thoracolumbar fascia's posterior layer. You'll learn about that a little bit more deeply as you take both ID1 and ID4, particularly in ID1. But we would love to give you $50 off. So Dr. Folckomer is going to write in our chat box here for you, Christine. She's going to write you immaculateDissection@gmail.com. You want to email her, and she will email you back with the coupon code, and you get to save $50 off of an online course, and they're $300 USD. That's a good chunk off, Christine. So very nicely done. For the people that also answered, nice job. A lot of correct answers. Christine just had it. She just was ready to go in with the correct answer. So we certainly appreciate you guys paying attention, and clearly you did, because that was at the very beginning of the class tonight. So woohoo, guys. Really glad that you guys were able to join us. And so if you didn't win this week, it's okay. You get another opportunity next Sunday. We're doing these until you guys tell us not to. These free immaculate dissection talks are really something we enjoy. They're really keeping us going during this pandemic, and we hope that you guys have shared in on the love. If you have questions for us, bring them to us next week, or post under our Instagram and when we announce the next Ask Us Anything. Thank you guys so much for joining us for Ask Us Anything episode 6. I'll be posting this onto YouTube tomorrow, and that will post onto the Immaculate Dissection Facebook page. So make sure that you go there tomorrow morning and maybe like it if you liked it, or even share it if you had a question on it that you had answered. We would love for more people to find out how we do these free webinars and get everybody educated. Thank you guys so much for your time and attention. Dr. Folckomer, anything before we go that you want to add?
Just thank you all so much. It's really fun I look forward to these every single week, and just spending a little time with you all on Sundays is just perfect. So thank you.
I feel the same way. Danny, anything else to add before we leave everyone?
Yeah, let's see. Oh yeah, cool. It's working. All right. Yeah, no, just super happy that everybody was able to come join today. I think thought it was really cool how all the questions were very connected today, and just kind of fed into one another, and kind of just evolved off of each other from there. So it was some great talking points in that sense, and it was just great being able to tag along, and thank you guys for being a part. So
that was pretty cool, right? That they all kind of asked the same kind of type of questions and they fed into each other. Pretty neat. Yeah. Dr. Kirby, anything to add before we leave? Oh, hold on, Dr. Kirby. There we go.
I've been really, I was just talking to Anna before, really missing. It gets nice to get to see everybody's video. I miss everybody. I miss seeing everyone, but this is really nice to get to see people's faces and to see people I know that before. So I miss you guys.
Yeah, we miss you too. We really miss doing the live courses with you folks. But you know what? We're rolling with the changes and adapting, and until we can all meet again, we're going to do everything we can to keep you guys educated and keep you guys fresh and excited about being a part of the ID family. Thanks for joining us, Kirby. Even though you're camping, is this your camper? That's a nice camper. Yeah. Wow. I'm going camping with Kirby and Danny, man.
Come on,
I want to do it. Love it. And Dr. Monica from Toronto, want to thank you for joining us. Any last words for the folks?
Just thank you so much. It's always nice to see you guys, and I definitely miss you all and love you all. Thank you so much.
We appreciate you coming in tonight to join us. So we hope to see you guys either on the ID Collaborative on Tuesday, or to see you guys at next Sunday's Ask Us Anything. We'd love to be able to provide information for you. Just let us know what you need. Email us at immaculateDissection@gmail.com. And Christine, make sure you email to get your coupon. And if you didn't win this week, come back next week. You can win. Get ready with that chat button. Get ready with the right answer. And if not, we just hope that it was worth your time to come in and talk some anatomy with us today. Hopefully we'll see you guys in the future, and have a great night. Bye.